This is Dr. Jolan Walter. I am the Robert A. Good Chair and Division Chief of Pediatric Allergy Immunology at University of South Florida and Johns Hopkins for Children's, and I'm excited to be here to share with you my thoughts on newborn screening for SCID from the perspective of a clinician and a researcher. Before we dive into SCID, or severe combined immunodeficiency, I would like to give you a brief introduction about this disease and what is behind the scene on the cellular level. First of all, when you think about SCID, you have to think about the T cell. The T cell have several roles. There are type of T cells that will directly fight infections, especially viral and yeast infections, and we call them cytotoxic T cells. The other subset of T cells help B cells to make antibodies and fight all other infections, and we call them the helper T cells. And then there are a unique subset of T cells called the regulatory T cells, which regulate inflammation on the mucosal surfaces. And T cells and B cells are in constant interaction throughout their development, and that interaction is vital in antibody production. So when the T cells are not present, they would not give enough signal to the B cells, and that combination of an abnormal T cell function or number with primary or secondary B cell abnormalities can result in severe combined immunodeficiency. So the definition of SCID is actually signifies this group of heritable disorders that have abnormal production and or function of T cells with or without primary B cell problem and natural killer cell dysfunction. So again, the mainstay of the disease is based on the T cell function and T cell numbers. And what we learned in the early 2000s when I was a fellow, that most of the patients were well appearing at birth since they had protection from the maternal IgG up to 6 months. And they did not really receive a diagnosis until that age, and some of them, or most of them, were actually surfacing with infections. And if they were undiagnosed before 6 months of age, the patient had a whole list of different infections, from yeast infections such as Candida to viral infections, respiratory syncytial virus or parainfluenza. Many of them had a slowly progressive disease called PJP pneumonia. We have seen patients getting first diarrhea and failure to thrive and then evolving into a full SCID phenotype. And unfortunately, we can make children early in life sick with vaccine-induced processes, such as live vaccine of BCG, polio, and rotavirus. As you can see on the right, this is an infant with an infection of the arm after the BCG immunization, and then the next slide next to it is showing a big lymph node enlargement or lymphadenopathy as a part of this process. And why is it important? When these patients have infections, their risk factor is much higher for mortality after bone marrow transplantation. So now we are fortunate that as of 2018, all states in the United States are screening uniformly for SCID or severe combined immunodeficiency. This is a historic milestone in the history of medicine, and the US is clearly in the forefront of this research and clinical care. And that has enabled us to now diagnose up to 70 to 80 SCID patients a year in this country. The assay itself is quite simple. The newborn screening card that we are all familiar with can have a little punch out, around a 3 millimeter punch, and that punch is going to be used for DNA extraction and amplification of a special DNA circle called a TREC, T cell receptor excision circle by real-time PCR that we will analyze. And back in 2010, a nice paper has reviewed this assay that was actually developed at the NIH by several investigators led by Jennifer Puck and Dr. Ki Chen. The T cell maturation in the thymus is a very unique process, and as the lymphoid progenitors are entering the thymus, they have to go through a unique process of VDJ recombination, as you can see it on the right. This recombination would create the broad repertoire of the T cells that would allow us to fight infections in the periphery. And during this shuffling of the genes, certain DNA byproducts are excised, and the circular product exists in the early T cell lymphocyte. And that little product that you can see in the image here would remain with a naive T cell, but get diluted with expanding activated T cells. So when we measure this little circle called a TREC, we actually measure the naive T cell compartment. And this is really a very unique way of finding patients with low thymic activity that could either reflect the absence of the thymus, such as a patient with full DiGeorge syndrome, or the absence of T cells entering the thymus, which happens in many cases of severe combined immunodeficiency. So with the newborn screening, we are really seeing a changing face of SCID. As I mentioned to you, initially most patients were either diagnosed by infections or occasionally with family history. And with the introduction of newborn screening, infection-related diagnosis is becoming less and less common, and newborn screening is taking over as the first point of diagnosis. And this is very good news, as we find most of these patients in asymptomatic stage. However, the bad news is that we will find many infants now who are not classical SCIDs. And these variants have to be interpreted, and the interpretation could be complicated. For example, for SCID variants, we have to decide where to draw the line for bone marrow transplant, or called hematopoietic stem cell transplantation. And other causes of T cell lymphopenia should be considered for milder variants, but it is also up to the physicians and sometimes the scientists in the area how far they are willing to go to evaluate these patients. So the current definition of SCID and its variant has been established by Dr. Shearer. He had a study where he have nicely differentiated the typical SCID in stratum A, who should receive bone marrow transplant. And these patients, besides having a very low number of T cells, also had low function, which means that the T cell did not multiply or proliferate well, and the function was less than 10% of normal with PHA. The stratum B or leaky SCID variants are a bit more complicated. In this group, you would allow for some number of T cells, but they are still reduced. In case of young children, it's less than 1,000 per microliter. And the T cell function proliferation could be also a little bit higher, but still less than 30% of normal as measured by PHA. There's a unique group of patients within this category called Omenn syndrome. These patients have generalized skin rash and have an expanding T cell compartment with oligoclonal repertoire. And this unique group is becoming more and more evident in the newborn screening process. As some patients are waiting for transplant, they can evolve from an asymptomatic leaky SCID to a more inflammatory variant of Omenn syndrome. And that is a very important clinical entity to be aware of. There are also some patients who have reticular dysgenesis, where they have severe neutropenias, and those could be linked to sensory neural deafness and other complications. And stratum C is a large area of investigations of our days. These patients are not going to be SCID patients. They would not qualify for bone marrow transplant, but some of these patients could potentially move on to further evaluation. And Dr. Shearer also sort of mentioned here a unique type of severe combined immunodeficiency that is related to the abnormalities in the ADA gene. When this gene is affected, we actually have an opportunity to replace it for patients who are waiting for definitive therapy, and this enzyme replacement therapy could be life-saving. So again, defining the variants of SCID in the era of newborn screening is bringing new challenges. We no longer can rely on the clinical presentation of the patient, at least on the history of infections. We can sometimes rely on extra lymphatic manifestations, such as microcephaly or failure to thrive, or other defects can present with additional features. But most of the time, we will not have a lot of clues on the physical exam. So we really have to go by the immunological definition, which will relate to the T cell count. So we will look for the T cell count In particular, we will look for the naive T cell count, and then we look for lymphocyte proliferation studies to mitogenes. And when I think about ancillary studies, it is important to really quantify the recent thymic immigrants as the key marker of this disorder, and that would require additional phenotyping, as you can see it in my figure, using CD45RA and CD31. You can also use ancillary immune studies to engage T cell proliferation with interleukins that can mimic a little bit more the antigen TCR engagement. Most importantly, though, and to us clinicians, most importantly, we want to get a genetic definition of the patient. In case of an autosomal recessive disease, we have to find two pathogenic variants, one on each allele, and that is not uncommon in REC deficiency, AD deficiency, or cartilage hair hypoplasia. And in case of the X-linked disorder, IL-2 receptor gamma deficiency, we would find one pathogenic mutation on the X chromosome. And the good news is that the genetic testing is now highly affordable, and several companies are offering genetic testing. Here, this is not limited to the 3 companies I'm mentioning, but we are really grateful for all the efforts that they have been building to help us to identify SCID patients in time with the genetic disease. But I must say, my clinical impression that sometimes finding the cause is not as easy as we would think. And the reason is that many of these genetic testing is focusing on the exonic regions. And we understand more and more that SCID patients can have intronic or 3' UTR variants, and that could be overlooked by the initial genetic testing. And I will bring you an example of that later in my talk. Why is it also important to differentiate the genes that could cause a SCID phenotype? Because there is 2 major categories of patients we don't want to miss during this process. And I like to contrast here SCID or severe combined immunodeficiency to athymia. As you can see in a normal patient, you would have a nice plump thymus above the heart. On the left, you can see the blurred like thymic shadow. Whereas on the right, the patient is missing that area, again, representing the fact that there is no thymic development. However, this thymic development is a process that is occurring as lymphocytes are interacting with the thymic tissue. And both athymia and SCID can result in this abnormality. Therefore, you really need to go after the gene itself or some other functional studies to differentiate the 2. And as you can see it here in red, SCID genes are listed on the top of my chart, and I highlight the ones that are one of the most common ones, and we are very interested in investigating them. Whereas athymia genes in the bottom in blue are the 22q11 deletion, FOXN1, and TBX. And the importance of this is that there is major difference in management of these patients. In case of SCID, you would be using a bone marrow transplant. It could be either hematopoietic stem cell transplant or gene therapy. And in case of athymia, you would actually consider a thymus transplant. It is still relatively complicated to arrange for thymic transplant. So that's something that we have to work on as a team here in the United States and beyond. But we still want to distinguish patients who fall into one or the other category. And as we went through newborn screening and there is increasing information on patients who were diagnosed through that process, there's a major difference in the distribution of gene defects. On the left, you can see that before newborn screening was initiated based on a European experience, nearly half of the patient had the XKID variant, which is the gamma chain mutation, followed by AD deficiency, and then the REC genes. And there were very, very few patients who actually did not have a known genetic defect. Whereas with the prospective US experience in newborn screening now, this has dramatically changed. And XKID is around 20% or 1 in 5 of the patients, followed by REC deficiency, which was less common in the past, and then AD deficiency. We also see an expansion of IL-7 receptor alpha variants here in light yellow. And most importantly, 1/4 of the patient, around 23%, did not have an identified genetic defect. And that again could mean that either the patients were missed for these other genes because the variants are hiding in deep intronic regions or other regions, or maybe promoters are influencing the expression of those genes, or there could be novel new variants which are currently on the rise in the SCID population. So again, this is an exciting time because the newborn screening experience is helping us to discover previously unknown genetic defects, even the immunobiology of these genes that is now linked to severe combined immunodeficiency. And what's more, I mentioned to you that REC deficiency is on the rise. So when we contrast typical versus atypical SCID in our newborn screening experience, you can see that this purple square, the purple color REC deficiency has dramatically increased in the atypical SCID variants. And why is it important? Many of our patients who have atypical SCID can have some T-cell compartment present, and they may be overlooked as T-cell lymphopenic conditions and not as a typical SCID. And REC deficiency is known to be sort of being silent a bit until the patient is getting herpes virus infections or other insults. So just knowing again the genetic defect behind an abnormal low TREC value would guide us to decide for early transplantation in these patients. And for that reason, we actually also looked into this other variant of REC deficiency called the combined immunodeficiency variant that comes much later in life. And what we have noticed is that these combined immunodeficiency variants could also potentially be picked up by newborn screening, but they had even higher number of TREC levels. And this is a very active ongoing research that we all would like to understand better so that REC deficient patients with combined immunodeficiency get early recognition and they don't evolve to the granuloma autoimmunity phenotype. As you can see on this, the face of this child with granulomas and autoimmune disease, if there's a chance to find them in time and potentially offer transplantation in asymptomatic change, it could be life-changing for them. So why should we care about the genetics in SCID? First of all, genetics may influence several factors in our clinical care. It would help us to make an absolute indication for transplant. If you have severe T-cell lymphopenia, but normal lymphocyte proliferation, which we actually have published about, patients may not get qualified for transplantation, but if you find a unique genetic defect such as REC or RMRMP with pathogenic variants, it is the likelihood is higher that the transplant team and the immunologist can come to a consensus to transplant these patients. The second modality why we really want to know about genetics is that how to treat these patients the best. So again, we all agree that these patients require transplant, but what is the best approach among the different options of transplant could be guided by the genetic testing. And in particular, when I think about differences of approach, could be hematopoietic stem cell transplant versus gene therapy. When you think about gene therapy for certain genes such as IL-2 receptor gamma, ADA, Artemis deficiency, these are currently available clinical trials, and in the pipeline we have REG, you really have to be 100% sure that what the genetic defect is what is causing the clinical phenotype. So understanding fully the gene defect and its implications, functional implication, is of high importance. There are also patients who have ADA deficiency and they would immediately qualify for enzyme replacement therapy. So early genetic understanding of these patients could help them to be protected before they move to transplantation. And then lastly, what we discussed already, that thymus transplant is an indication for DiGeorge syndrome, and thymus transplantation is an indication for DiGeorge syndrome, and therefore we want to have early recognition of this transplantation, of this syndrome, so that thymus transplantation can be arranged. And lastly, we have to consider other causes of T-cell lymphopenia, and they could be just as important in the early diagnosis and treatment approach. And I will have a few examples of that later in my talk. So again, I hope I could emphasize enough in this slide that genetics has significant importance in influencing both the indication and the selection of best treatment for transplant and enzyme replacement therapy. However, it could be that pathogenic variants are actually not present, and then we have to make decisions without having an actual gene in our hand. And that could be quite a challenge for the clinicians. Going blindly for transplant is never easy, and we would do anything we can to understand the family with their variant. So I would like to share with you now a challenge when we were trying to find and confirm a pathogenic variant through a paper that we recently published and some of the follow-up story. So this is a little boy who came to us actually not through newborn screening, unfortunately, because his card was insufficient for screening, but he came to us already in a disease state with infections. So he came to us at 9 months of age, and we really could not find a genetic disorder as we were getting him ready for transplant because he had no genetic variants in the IL-2 receptor gamma gene. And this is the patient who had the novel variant in the 3' UTR. So we decided to investigate this patient, and we did certain readouts, such as IL-2 receptor gamma expression. We looked at IL-2 receptor gamma signaling, and X-linked activation studies in the carrier mother who had the same variant in the 3' UTR. And the X-linked activation study in particular was very convincing that this is indeed probably a pathogenic variant. We did again a lot of studies for the patient who had the 3' UTR. We published the case, but we still had some doubts whether we could really justify the finding as being pathogenic. And then a second patient was born to the same family. This second child also had an SCID phenotype, and we found the same genetic variant in the 3' UTR in this child. So now having two affected child and one mother who is a carrier, we are getting even more comfortable of defining it as a likely pathogenic variant. We are still working on additional functional assays to prove or disprove the importance of this variant. But the reason why I wanted to emphasize this paper in particular is that the genetic finding really would allow us to move this patient to gene therapy, the second patient to gene therapy. And it's still an ongoing discussion what is the best treatment for this child, but the fact that he could qualify for gene therapy or any other family members is very reassuring to us. The same paper from Frontiers in Pediatrics also reports another family who had where the child had an early missense variant at position 175, and that variant was reported as a variant of unknown significance. And we had to do our diligence to look at the IL-2 receptor gamma expression again, the signaling and X-linked activation studies for this family as well. And by doing our diligence in functional assays, this patient actually qualified for gene therapy trials, and now he is 5 years out, doing great after gene therapy. So this sort of tells us that we have to go as far as we can in understanding the genetics of our SCID patients, and that could really influence long-term clinical decisions and family planning. So just very quickly, I wanted to emphasize to you some of our tools that are, some of them are not research-based, but some of them are now coming to the clinical grounds. We really need to advance on genetic testing. The first one is X-linked activation studies in maternal T cells. As you have seen in the previous slide, it is of high importance to establish a patient with a possible X-linked disease, and all you need to do is really looking at the maternal T cells and their X-linked activation. And that could help to interpret a VUS, such as the second case that I showed you, or help to even look for variants outside of the exons to the introns or the 3' UTR. The second important assay that we really would like to discuss here is an assay that is available at Nationwide Children's. This is called the radiosensitivity assay or testing, when we look at DNA repair in the patient cells after irradiation. We can actually distinguish two major categories of patients through this assay. The first one is SCID variant with non-homologous end joining defects, including ligase 4, Artemis, Cernonos, or DNA PKs defect. And all of these patients would require a very unique approach, possibly no conditioning or reduced intensity conditioning. This is in contrast of patients who could have ataxic telangiectasia, which is a much slower progressing disease. It is not considered a major common immunodeficiency, although patients can decline with immune function with age. And when you have a T-cell lymphopenic condition, this could also be helpful when you have a radiosensitivity assay to prove that the patient have that condition, and you look for some gene defects in this particular ataxic telangiectasia gene. And lastly, I'm a really big fan of repertoire testing, because even if we don't have T cells, sometimes we have some B cells, and looking at their receptor repertoire and diversity by genetic testing or flow cytometry could really give us a guidance on VDJ recombination defect, which is a unique variant of a SCID when you have this abnormal receptor rearrangement in the thymus for the T cells and in the bone marrow for the B cells. And REC deficiency and non-homologous end joining defects, as above, can both result in this phenotype. And just looking at the repertoire itself could give us a clue whether we want to go down that path for additional genetic testing. Beyond the functional assays and the tools that we have to use now to prove or disprove genetic findings, I would like to also emphasize a new line of research that is becoming extremely important around the world, is genetic testing for SCID from newborn screening cards. Of course, this is not an easy process, and most of our public health system has not embraced it yet, but I think this time will come. And it is requiring more infrastructure than the typical TRECs screening process. We have to consent the patients who will be undergoing genetic testing from these cards. There have to be a very robust sequencing panel available. We need strong bioinformatics support. Again, we have to use functional studies to prove or disprove the pathogenicity of the mutations. And sometimes we need to go for a third layer of genetic testing with whole exome or whole genome. And whatever we find, we have to then relate it to the families. So counseling for patients from this information could be demanding. But I personally think that it could be a very useful tool, especially in the developing world, when patients are far away from academic centers, and getting blood samples to the sites could be really difficult, whereas newborn screening cards are long-lasting and they are stable, and genetic testing could be highly feasible from that. And we are already seeing great efforts in the Middle East, in the United States, and some of the European countries, in Latin America for these efforts. So I really hope that this could be coming in as a second generation of newborn screening tools, and we all would be doing research in that regard to advance this field. Lastly, I would like to talk about unique T-cell lymphopenic conditions that could be identified by newborn screening. As I mentioned to you, there are some patients who would come with low TRECs, but not as low as a typical SCID. And on the lymphocyte panel testing, we find them to have some lymphocytes, but not as low as the SCID patient's lymphocyte count. And we have to make a decision where to go and what to do. And many of these patients could have benign lymphopenia. Some of them can have secondary lymphopenia because of ongoing diseases, or they can have a bit of a T-cell abnormality with abnormal timing development. So the most common condition currently is considered to be the George syndrome. However, there's a new entity that we are noticing now, and we would like to have people's attention on it, and it is called WHIM syndrome. So WHIM syndrome is actually a unique entity with a combination of warts, hypogammaglobulinemia, infection, and myelokathexis. And it is related to the CXCR4 gene. Most of the gene defects are occurring in the C-terminal of this receptor. And when there is a mutation, then the receptor cannot stop signaling, and this is a gain of function variant. And what we learn in WHIM syndrome is that although the syndrome acronym starts with warts actually would not appear until later in life. And even hypogammaglobulinemia and infections could come with age. So the only phenotype of the disease that we could see anytime in a patient's life is myelokathexis. Myelokathexis is the retention of mature neutrophils in the bone marrow. And as you can see, you require a bone marrow biopsy to diagnose these patients, and it is still operator dependent to interpret the information. So it is not uncommon that patients with WHIM syndrome are overlooked and they may be diagnosed much later in life in the absence of a bone marrow biopsy and an experienced reader of the slides. So for that reason, we got very interested in how to find patients earlier in life, and we were very much of a proponent of genetic testing among patients who could be having this disease. And one of our projects was actually focusing on the newborn screening process to understand if patients with WHIM syndrome could be identified with a simple TREC assay. And what we have found in a paper that was recently published in the Journal of Clinical Immunology is that 3 of the 6 patients who had WHIM syndrome diagnosis during the past 10 years of the newborn screening era had actually low TREC levels, and all infants had evidence of severe neutropenia at birth. And the only time that they would increase the neutrophil count if they were finding infections. So what really made this syndrome unique is that when you combine a low TREC level with a simple neutrophil count, you could increase the likelihood of finding a patient with WHIM syndrome. And now we are excited that this finding has been embraced by some of the newborn screening developmental committees, and they are interested in putting out guidelines to consider a CBC or complete blood count for neutrophil count in the context of a low TREC. And it's possible that once we have these patients identified, we could consider them for WHIM syndrome diagnosis and treatment. So overall, I hope I could convince you that we have a great mission now in our field in immunology, in the field of newborn screening, to help patients who otherwise could have high mortality and morbidity throughout life. We believe that in the era of newborn screening for SCID and other PIDs, we have an unprecedented phenotypic and immunological diversity, and therefore we need to use several tools to understand the underlying disease process. We have to use advanced diagnostic studies, which could mean lymphocyte subsets, proliferation assays. We definitely need to search for genetic cause in this patient by targeted sequencing or whole exome. We have to use confirmatory functional assays to prove or disprove the genetic findings. And this all has to continue through research as well, including both molecular, cellular, and genetic studies. And this ongoing research will help us to not only help with the early recognition of specific SCID disease, but make them qualify for targeted definitive treatment, such as gene therapy or bone marrow transplantation, and overall help families to be prepared and do family planning. And this is a work that we cannot do alone. So our team here in Florida has several multidisciplinary teams working together, including the bone marrow transplant team, pulmonary rheumatology, GI. We work with several centers, and we try to bring this knowledge, what we find in newborn screening, to adult and adolescent medicine as well. Because currently we do a very good job in finding young children, even in asymptomatic stage, but we still have difficulty finding similar, like partial immunodeficient patients in the older age group. And so I'm really grateful for the opportunity to talk. This is my contact information, and we have a great team here, a research team and clinical team at Johns Hopkins Children's and USF Research Institute. And we hope that we can serve you in Florida. Thank you.